Today we have Professor Ginger Jain from University of Maryland and NBR with us, and Ginger has very influential work over the years in industrial organization. Today she is going to talk a little bit about top-up design and healthcare expenditure with evidence on cardiac stents from Taiwan. Um, Ginger, you have 60 minutes, out of which 45 minutes is the talk and 15 minutes for open Q&A. And I will help you moderate in between if there are questions in the chat window. And around the 20th minute, you may want to pause and check if anyone has a question. So over to you, Ginger. Thank you very much for making time for us.
Thank you for having me, Chirantan. It's great to be here. I appreciate every one of you taking time in the dinner time of Friday to attend this seminar. I really appreciate that you guys accommodate the flexibility of my schedule. Thank you so much. This work is joined with Xianming Lian at National Chengxi University in Taiwan and Xuezhen Tao at Shanghai University of Finance and Economics in China. Let me see if...
Ginger, are you okay with recording?
I'm okay with recording. I'm trying to figure out why.
Okay.
Yeah, go ahead and record it. Okay. So we know in many countries, the medical insurance system have multiple goals. One goal is to provide coverage for treatment procedures. Another goal is to control for the overall medical expenditure, especially if the medical insurance system is from the public sector, then controlling the expenditure is one of the primary goals of such national insurance system. There are multiple ways to do that. So for example, in UK, Australia, France, or Germany, they're using a system, what the academics call no top-up. So this system, they're basically going to choose one or multiple treatments that they deem to be cost-effective. And then once they think those treatments are cost-effective, the insurance plan would cover that in full, but then they're not going to cover the other treatments. Okay, so the other treatments typically will be more expensive, maybe newer treatment will be completely excluded. For example, in UK, the threshold for so-called cost-effective is that the expenditure should be below $50,000 per quality adjusted year of life saved. So this system tends to just cover the basics and not including more expensive and potentially more effective, more efficacy and newer treatment. The other extreme is like in the US, the insurance system would cover all treatment options, whether they are expensive or cheap. However, you can imagine this will generate more hazard. If it's the same costly to get newer and more expensive treatment, of course, patient would take that option. So in order to address the moral hazard, such insurance system typically would have terms on copay, on co-insurance or deductibles, but those terms are not enough to fully address moral hazard. So for example, for say cancer or other diseases, once you pass the deductible threshold, typically, the more you use, the less fraction of money will be paid by the patient. So that implicitly would encourage patients to choose more expensive treatment. So you can see these two extremes. One is very like bare bone, they only cover the cost-effective treatment and try to discourage people from using any new and expensive treatment at all. While the other one is the opposite. It may encourage too much use of those expensive treatment. So with that, people have been searching for a middle ground, and this middle ground will be called top-up design. And in very short description, that means patients are covered for both cheap and more expensive treatment. However, they will need to pay the incremental cost of the more expensive treatment beyond the basic coverage from the insurance. Theoretically, this top-up design is supposed to be more efficient in sorting patients across treatment. Those who have a higher willingness to pay and more able to pay probably will pay the incremental cost and choose a more expensive treatment, while others may prefer to stay with insurance and just pay very little for the basic treatment. This has been demonstrated in Chernews and his co-author's paper in 2000, that's Journal of Health Economics. Empirically, N.I. Finkelstein and Williams have shown in the example of breast cancer treatment that such top-up design does bring welfare gain. So as compared to full coverage, it will bring, they calculated the per patient welfare gain is about $700 to $1,800. And that's because it got rid of non-necessary use of expensive treatment. On the other hand, if compared to the no top-up regime, the top-up regime can bring welfare gain about $700 to $2,500 per patient. And that's because the top-up design would increase the use of newer and more expensive treatment for the patients who are willing to pay for the incremental cost. So these papers focus on the demand side, ignoring the fact that health providers probably will have incentive to distort the quantity and quality of health service in response to the top-up design. However, we haven't seen much empirical papers looking at questions such as, does top-up design actually induce moral hazard on the health provider side? To what extent do hospitals actually raise the price of more expensive treatment in order to extract profits from patients? So we're going to look at this question in the context of Taiwan. As you know, Taiwan has a national health insurance system. It's a fairly generous system. It reimburses cardiac stents based on the top-up design. More specifically, in July 2006, Taiwan's NHI has a top-up design applied to 11 expensive medical devices, including such as pacemakers or cardiac stents and so forth. All the stents are reimbursed by the rate of the basic treatment, which is the bare metal stents, at the cost about 20K new Taiwan dollar per stent, which is roughly equal to about 660 US dollars. If people choose to use more expensive treatments such as drug-eluting stents, then there will be additional cost paid by the patient. That additional cost is actually quite substantial. It's about 60K local currency per stent. That's roughly 2,000 US dollars. If you compare this number to the GDP per capita in Taiwan, this is about 8% of the annual GDP per capita. So that's a substantial amount to be paid by patients should the patient choose to use drug-eluting stents. So with this context, we're going to study the top-up design in this market. The stent payment is set by the average bare metal stent cost reported by all hospitals to the National Health Insurance plus 20% markup, and the price is set to readjust every 3 years. Particularly in January 2009, the National Health Insurance has lowered the stent payment by 26%. So this is the largest drop in the history. I'm going to show you more data on this. So using this as a pseudo experiment, we want to examine how hospitals respond to the reimbursement rate cut under the top-up design for cardiac stents. In particular, we asked, do hospitals push more patients to use stent? Do hospitals use more stents per patient? Do they increase the price of more expensive drug-eluting stent treatment? We actually not going to say much about the first margin. First, because the data, I'm going to show you some evidence that the data does not show any any evidence supporting this hypothesis. And second, we talked to many doctors, and doctors told us that it's actually pretty difficult to just switch patients from not using stent to using stent until there is medical ground to justify that decision. So we believe this margin is pretty hard to manipulate. I'm going to show you some rough statistics on this. So our main empirical exercise would focus on margin 1 and margin 2. Just to preview the results, after the rate cut, hospitals' quarterly revenue from cardiac stents on average dropped by about 15%. On average, we find that the number of bare metal stents, that's the basic treatment, per stent patient actually increased by about 18%. But there's no significant change on the number of more expensive treatment, which is the drug-eluting stent. So in other words, we see every stent patient somehow receive a larger number of basic treatment, but no change in the number of more expensive treatment. And the increase in this basic treatment is concentrated on minor teaching hospitals, not in major teaching hospitals. You can think of the major teaching hospitals to be sort of well-known academic centers, while minor teaching hospitals are more regional. And we also couldn't find any significant change in the price that patients pay for the more expensive treatment. However, we do find the probability of two vessel treatment in the PTCA surgery to increase. Actually, you have to treat the vessels first before you implant the stent. So we're going to give you more medical background of why this is relevant. Okay, so in total, we find these responses from hospitals is able to offset some revenue loss due to the rate cut. It's offset the revenue loss by about 15 to 47%. In other words, by the rate cut, the national health insurance does reduce the total expenditure on cardiac stents, but not as much as you would imagine in the ideal world. The moral hazard from hospitals was able to get back some of the revenue loss, but not all of that. Okay, so that's our basic result. In terms of, let me give you some background. The stent treatment is a very well-known treatment for cardiac situation. Typically when patients have a heart attack or chest pain or other heart problems, they will choose between CABG or PTCA. CABG is a bypass surgery. Basically, the doctor would try to get around of the vessels that got blocked and probably use the patient's other tissues to get a bypass to that. That's a major surgery, open heart surgery. PTCA is less invasive. It's basically going to send a balloon, a deflated balloon into the area around the blocked vessel, and then use a media to inflate the balloon to force the vessel to open. Okay, I'm going to give you some graphic presentation on that. You will have a sense. However, the PTCA treatment would have a side effect because the blocked vessel got opened by this procedure, but may become reblocked with some probability. And that probability is relatively high if the PTCA surgery, it just dilates the vessel by a simple balloon. And that's about 30 to 50% restenosis rate. Okay, that means the same situation would reoccur later on. But if the surgery also use bare metal stent, that's the basic treatment in cardiac stent, that can reduce that restenosis rate to about 10 to 20%. If they use more expensive treatment, the drug-eluting stent, it can further reduce the restenosis rate to about 5 to 10%. Okay, so conditional on the patient will implant stent, doctors and patients would jointly determine which brand of the stent to use and how many stent to use on each vessel. Well, when I say doctor and the patient jointly determine this, I would say probably mostly by doctors. We have asked a lot of doctors how they make this decision, and almost all of them tell us that patients know very little about this. Whatever choice they present in front of patients, patients tends to accept that. Okay. So just to give you some sense about the treatment, if there is a heart problem around a vessel, then the PTCA surgery could put a little device like this through the narrowed vessel, okay? And then from external media, they can inflate this balloon, which force the vessel to become bigger, okay? And then they can somehow withdraw this balloon and leave a metal mesh here. And this is an example of stent, okay? The stent could be bare metal stent, which just means that it just made of metal, is supposed to be there permanently. And if it's a drug-eluting stent, the metal also have some drug on the surface of it. It's supposed to be slow releasing drug to prevent the vessel to become reblocked.
Ginger, I had a quick question.
Mm-hmm.
So this margin of CABG versus PTCA,
Mm-hmm.
can you observe that in your data? Because it looks like that's a big welfare trade-off.
That's true. We don't observe that in our data. Our data is conditional on PTCA patient. Actually, not all PTCA patients use stent. About only 60% of PTCA patients use stent. So that's why I was saying that this is the margin zero. That's in theory, the doctors could persuade more PTCA patients to use a stent. I think this margin probably more relevant than the choice between PTCA and CABG.
And the other thing was, you said patients tend to believe doctors, but
Mm-hmm.
within stenting, isn't there emergency and elective stenting kind of behavior? So sometimes you may have a sudden heart attack and the doctor has to immediately stent you versus you're going for your routine annual checkups and we discovered that there's a blockage and you have to be stented. Um, is that observable? Like in Indian data, you can actually observe that, whether it's an
I think
emergency or a elective.
we do observe the diagnosed condition in our data for each patient. I think in the emergency acute situation, as you describe, the patient probably either would have to go to CABG right away because the block is so severe,
Right.
or the doctor would put some stabilizing treatment before they do the PTCA. PTCA is meant to not for the most severe patients in this area. So that's why actually most PTCA surgeries are selective. So once you go through the first stabilization process, you will have time to talk about like how many vessels may subject to stent treatment, how many stents you will need in each vessel, and what brand of vessel, what brand of stent is more effective for this type of blocking and so forth. So, I mean, our knowledge is that this is mostly selective surgery procedure rather than an emergency type of procedure.
Got it. Thank you.
Yep. And will control for the individual patient condition.
Okay.
So just to give you some numbers, cardiac stent is actually a very important driver for medical expenditure in Taiwan. The number of stents implanted per year has more than doubled from 2007 to 2014. The medical payment for stents have increased a lot as well, from 3.5 billion local currency in 2010 to 5 billion in 2014. So the massive reimbursement and rapid adoption of stent make it really well suited for our question. This table gives you the policy change because the price is supposed to change every 3 years. it's fair to say that hospitals and doctors are expecting this change, but they don't know the exact timing of the change or the exact magnitude of the change. So we're going to focus on the 2009 change, which is the largest amount between 2006 and now. Okay. So our data has 2 years before this change and 2 years after this change. So it goes from 2007 to 2010. We have individual patient medical record that would include patient demographics, their diagnosed conditions. We also know the brand and quantity of stent used per patient. In total, we have almost 130,000 patients. This is what we call PTCA sample. About 61% of them have some stents implanted. So conditional on they have stent, we'll call that stent sample.
Are these all private hospitals?
I think most of them are public.
Okay.
Yeah, it's, if I remember correctly, probably only less than 10% of patients are in private hospitals, but most of them are also nonprofit.
Got it.
Okay. We also have the price patient paid to the hospital for drug-eluting stent. And this data is collected from NHI website because NHI require every hospital to report this price data to them on a, I think supposed to be on a quarterly basis. So we have those observations periodically from the hospitals. We're able to match to the individual patient record for about 90%. So just to give you some sense of number of PTCA patient and number of stent patient, the red line here is showing the number of PTCA patient is increasing over time, and percent of a number of stent patients is increasing as well. However, the fraction of stent patient is about 60%. It's slowly rising, but we don't see a huge jump around this policy change. The second line is showing the percentage of patients, the percentage of PTCA patient using the drug-eluting stent. Remember, this is the more expensive treatment, and that percentage slightly going up over time. I probably should stop here if you guys have any question.
So Kunal, can you unmute yourself and ask your question? I didn't get exactly what the question is.
Actually, my question is that in congenital patients, if they have a birth defect, then which one is the best? Is the metal shunt or drug illusion? Which can economically be the best? What is the economical difference between them?
In congenital patients, he's asking. So
with
defects that are congenital in the heart.
Oh, okay.
They might be by birth.
Congenital patient. Yeah, that's a medical question. I'm not sure I have answer to. If you look at the medical literature, there are tons of literature talking about which brand of drug-eluting stent is good for which type of patient. I think the general understanding is that the drug-eluting stent is probably on average better than the bare metal stent, but that difference may vary by patient condition. Actually, for very severe patients, I have read articles actually recommend them using the bare metal rather than drug-eluting because the drugs may have some interaction effect with other drugs they take or with some conditions. I think, if I remember correctly, for patients with sort of relatively severe conditions, it seems like the recommendation is they should use the basis treatment rather than the drug-eluting treatment.
Okay, any other questions, folks? Doesn't look like. You can keep going.
Okay, thank you. So this table gives you some sense of what's the difference between major teaching hospitals and the minor teaching hospitals. You can see that typically the percentage of PTCA patients using stent is higher in major teaching hospitals. And also conditional on using stent, the percentage of using drug-eluting stent is higher in major teaching hospitals. And all those percentages are increasing over time in both type of hospitals. Here, I'm showing you statistics conditional on a patient using stent. On average, they will use about 1.3 stent. That could be they're using one stent per vessel, or could be using multiple stent in a single vessel, okay? And you can see that out of that 1.3 stent used per stent patient in 2007, about 0.87 were used in bare metal stent, while the other 0.45 is used in drug-eluting stent. Okay, so if we look at average number of stents used per stent patient, you can see that it seems like there is a very large jump around this time that NHI reduced their reimbursement rate for stent, okay? If we decompose that to the bare metal stent versus the drug-eluting stent, it seems like the jump is mostly driven by the bare metal stent, but the drug-eluting stent have a trend that seems not breaking around the January 2009. Okay, so if we look at the patient paid price for drug-eluting stent, it is rising, but it was rising even before January 2009, but becomes stable or even going down a little bit after 2009. And this trend, I should say, there are a lot of factors behind this trend, because the medical device companies keep on pushing out new models of drug-eluting stent. So there's a natural new model adoption, dropping the old model, and that new model typically were adopted earlier by major teaching hospitals and then followed up by minor teaching hospitals and so forth, okay? But the point is that this picture at least not showing too much that this price, there is any significant price increase that could be attributed to this January 2009 reduction of reimbursement rate. The red line was just literally showing the reimbursement rate drop. Yeah, go ahead.
Ginger, do you observe the brand name of the stent used?
We do, yeah, we do.
Awesome. So you probably can throw in some brand fixed effects, like Abbott is trying to push certain advanced version of drug-eluting stents, and you can control for those promotional effects on physicians.
Right, yeah,
Analysis, right? So.
Yeah, and we actually, in this paper, we're not doing too much analysis on that. Just in one analysis, I will show you, we actually control for the model fixed effects. By model, we defined it by brand name and the model name.
Yeah, I mean, the reason I ask is when I talk to these Abbotts and Medtronics of the world who are in the stent space, the feedback I get is stents, they are there purposefully because ex ante it's filled with so much uncertainty that it's easy to game the social planner and get into reimbursement mechanisms, because you can't really follow up with patients 6 months, 1 year down the line and look at welfare health outcome effects. So it's from a firm perspective, it's perfectly incentive compatible to get into a product market which is so much more uncertain for the social planner and the patient and the physician to know whether it's yielding true welfare effects in terms of health outcomes. Yeah.
Yeah, I'm totally with you. Okay, you may wonder that maybe the increased use of bare metal stent is because the underlying health condition of the population have changed. And here we show you the, for example, the gender and age distribution, and it's not changing much. We also show you the distribution of health conditions. It doesn't change much either. Lastly, we show the distribution of number of blood vessels treated by PTCA. Remember that a blood vessel has to be treated before you implant the stent, but a treated vessel does not necessarily implant the stent. So you can see that the majority of them have one blood vessel treated. About 30% of them have two blood vessel treated. And this one vessel ratio seems going down over time, but then going up a little bit. So that's why later on we're going to look at how the number of vessels might be a potential margin for hospitals to respond to this rate cut. And the reason was not only because the blood vessel treatment is a necessary condition before you implant the stent, but also because the PTCA blood vessel treatment was reimbursed separately by the National Health Insurance. So that rate does not change around 2009.
Got it.
Okay. Yeah. So so I'm going to be very quick on our estimation model. You may think of maybe we should do DID, but it's every hospital here is treated, so it's very hard to find a control group. You may also think about maybe we can do the regression discontinuity. However, because this surgery is selective and typically scheduled weeks ahead, it's pretty hard to see the immediate effect. Well, at least in theory. So instead, we use a model that account for differential treatment. And we focus on variable, what we call a ratio 0.8. This is the number of, well, I should write it as percentage of stent patients among the PTCA patient in the hospital as of 2008. You would imagine that a hospital has a lot of PTCA patients using stent, would have a lot of hospital revenue from cardiac stents. So that means the rate cut in cardiac stent will be a bigger shock to them. Okay, so we want to see whether the hospital subject to a bigger shock would respond differently from hospital that's subject to a smaller shock. So that's our main identification. The interaction of this variable with the dummy after the treatment will give us the differential treatment effect after we control for patient characteristics, hospital fixed effects, time effects, and so forth. The outcome oh, I'm sorry, go ahead.
Mayank had a question that in late 2000s, there were reports of stent thrombosis associated with drug-eluting stents, questioning their efficacy. But I think you have time-fixed effects.
Yeah, we do have time-fixed effects. So that should control for that, as long as that's common for every patient.
My other worry, Ginger, is the unit of observation should be a physician patient, right? If you have that data, because physicians are idiosyncratic, and we know from Tom Buckmiller's work in opioids that the ones who are trained in elite medical schools tend to be more conservative about prescribing versus the others. So would you be able to observe physicians with, let's say, overseas MD degree in your data?
We do. I think at some point we have tried to cluster by doctor ID, but eventually we decided to cluster by hospital because we're not sure whether they price raising or more induced demand decision was made by the doctor or made by the hospital, or sort of jointly, that maybe the hospital was pushing the doctor to generate more revenue and through bonus or other performance measure. And that's the black box. So just to be conservative, that's why we end up clustering the error by hospital rather than by doctor.
So you would say that lambda is an underestimate? I mean, it's biased downwards.
For what reason?
Because you're sucking up the idiosyncrasy that the physician may bring in those alternative regressions or something like that? Or does the fact that a doctor is in a teaching hospital is probably on the margin better trained than a doctor in a minor teaching hospital? That takes care of that issue, perhaps. Anyways, I'm rambling, so please go ahead.
Okay. Yeah, I was thinking more about it. We do have hospital fixed effects though, so that probably account for the second comment.
Cool.
Okay, so let me move on. So then naturally we want to see whether in the raw data we see such pattern, right? So we separate the ratio, we separate the hospital into 3 groups according to their ratio 0.8 and see how they change differently before and after general line. And you can see here, this group is the one that has the highest ratio 0.8, okay? And this one is the medium, and this one is the low. So you can see that the change in the number of stent used per stent patient seems to be the highest for the high group of ratio 0.8. This is a group that's subject to the biggest shock because of the rate cut on stent. Okay, so the regression is very straightforward. We do this regression for number of drug-eluting stent and bare metal stent separately. You can see that if we control for hospital fixed effects here, then the magnitude of the coefficient drop a lot. It's never significant for the number of drug-eluting stent, but it remains to be positive and significant for the number of bare metal stent. So in other words, this seems to suggest that the hospitals subject to a bigger shock because of this rate cut tend to increase the number of bare metal stents used per stent patient. If we try to see whether this is driven by major teaching hospital or minor teaching hospital, what we find is that it's actually purely driven by minor teaching hospitals. And if we try to see, okay, is the number of bare metal stent increase driven by more people using bare metal stent, or every such patient using a higher number of bare metal stent? The answer is probably both margins are at working. We can see that the probability of a patient using any bare metal stent increase about 10% here, while the number of bare metal stent conditional on that you are a bare metal stent patient has also increased for minor teaching hospitals. So that's our first margin. We also did some nonlinear version of this by separating the ratio 0.8 in 3 groups, using the lowest one as the baseline and just to see how the high and middle one different from that. It seems like the biggest response was from the high group. The hospital that has the highest is basically in the highest 1/3 of that ratio 0.8. Okay, so just to recap on margin 1, we find that patients use more cardiac stent once we control for hospital fixed effects. And the increase in stent use is basically driven by the bare metal stent, not the drug-eluting stent. This makes sense because patients pay nothing for the bare metal stent. They agree to have more stent implanted in the patient. In comparison for drug-eluting stent, because the patient has to pay a significant amount, it's not that easy to persuade patient to use drug-eluting stent. So we think this response is totally reasonable. And we also find this response was mostly concentrated in a hospital with high percentage of stent patient before the rate change, and is mostly from minor teaching hospitals. For the second margin, we want to see whether the rate change would change the price of drug-eluting stent. If you look at a full sample, we don't see any sign of price increases. If we break it down into major teaching hospital or minor teaching hospital, we see a very weird situation where if we just control for hospital fixed effects, the major teaching hospital seems to reduce the price, while the minor teaching hospital seems to increase the price. But once we control for the stent model fixed effects, those effects basically disappear. So this probably suggests that the major and minor teaching hospitals have very different pattern in terms of adopting stent models. And that is generally true, that the major teaching hospitals are earlier in adopting the new stent models, and almost all new models are drug-eluting models. So we further look at like what's the percentage of patients actually using the new models introduced to the market on and after 2009. And we find that hospitals with high ratio 0.8 tends to have a fewer patient from those new models. If we break it down by major teaching hospital and minor teaching hospital, again, this seems to be driven by minor teaching hospital. So just to recap, we don't think there's any convincing evidence saying that hospitals actually raised the price of drug-eluting stent after the rate cut. One possibility, well, we don't know exactly what's going on, but our speculation that was true before and after the rate cut. The minor teaching hospitals of high ratio 0.8, subject to the bigger shock from the rate cut, are less likely to devote stent use to new models, but they may direct patients to more expensive old model, and that explains why from the raw data seems like they have increased the price for the drug-eluting use. Okay.
These
so,
are, could I ask a quick question here?
Yeah, of course, go ahead.
These are not electronic medical record database, right? These are insurance claims.
Yes, these are insurance claims.
So you don't know if patients are getting readmitted or something?
We probably do. I think we do see some patients get back to our data, but that's probably because they have another cardiac pain and
I see.
goes through another PTCA. I mean, we don't know exactly which vessel was operated on in the first surgery, so it's hard to tell whether this is just a readmission of the old condition or new condition. It's not that common though.
Yeah, I'm thinking about the welfare effect. So yeah, okay, please go ahead.
Right, yeah. We probably should think a little more about that too. Yes, yeah, that's a good question. So we have done a fair amount of robustness check, like placebo test in 2007, pretend there was a rate cut at the beginning of 2008, and we don't find any impact on the stent use. We also try to exclude the second half of 2008, just in case the hospitals can anticipate the rate change. We also excluded hospitals with fewer cases, just in case those outlier hospitals may driving the results. In 2009, the National Health Insurance System also relaxed the maximum number of stents they can reimburse. It goes from 2 to 3. So you may think that could be a reason for the number of stent to increase. To address that, we recode 2+ stents as just a 2 and rerun the regression. We still find significant impact. So I would say at least a part of the number of stent use increase we found in the data was driven by the rate cut. Okay, so then we ask ourselves, how could doctors do this, right? How can they persuade patients to use more stent? One way to do this is they can say, okay, now you actually have 2 vessels blocked rather than 1 vessel. Okay, I'm going to do PTCA surgery on both of them, and then now both of them would need a stent. Okay, so there is incentive to do this because hospitals can generate extra revenue from more vessels treated, even if that vessel is not using any stent. So just to look at this possibility, we look at a variable that indicate a number of vessels treated under PTCA. So that's 1 or 2 or 3+. We also examine whether this mechanism changes by age, gender, or health condition. So conditional stent patient, because they use stent somewhere, the number of vessels treated must be 1 or above, right? So we just look at the dependent variable of whether you have 2+ vessels treated or whether you have 3+ vessel treated. So if we regress the number of, if we regress the dummy of having 2+ vessel treated, on our key variable ratio 0.8 multiplied by the dummy of after 0.9, we find in the full sample, there's a marginal significant result that we do see the probability of treating 2+ vessels has increased about 9% for the ratio 0.8 high group, okay? And if we decompose this into major and minor teaching hospitals, oh, whoops. Again, we see this is driven by the minor teaching hospitals. However, we don't see any results for vessel 3+. So this means that the margin at work is probably going from 1 vessel to 2 vessel rather than from 2 to 3. Okay, so we further look at how this mechanism differ by gender or by age or by the condition. Basically, we interact the demographics variable in the vertical column title here with our key ratio 0.8 times after 0.9. So we're reporting the interaction coefficient here. The only thing that seems to be significant is here. It seems like this increase of number of vessels is more apparent in patients with AMI condition. AMI condition is relative acute and emergent condition. So it seems like the hospitals are saying, well, you really have a problem, this is acute condition, and that may be the situation that they're able to persuade the patient to accept more blood vessels to be treated by PTCA. Okay, so what does all of these mean? From the NHI point of view, if those moral hazard cancel off the attempt to reduce medical expenditure through the rate cut, that will be a very bad news, right? From a hospital's perspective, their revenue loss is substantial given the NHI rate cut. If these moral hazard behavior is able to help them to generate extra revenue loss, the hospitals would be relatively better off as compared to no moral hazard in face of the NHI rate cut. Okay, so we try to do the back of envelope calculation, say, okay, let's first look at the counterfactual BMS use if the rate cut is not there. Okay, we do this, say we take the 2008 actual number minus the 2008 fixed effects plus the 2009 or 2010 fixed effects. This would account for the natural trend in our data. Okay, and then we say, okay, that's the counterfactual number of stents times the degree of rate cut, that's the expected revenue loss. Okay, and then we can calculate the recouped revenue through either the extra use of stent, so that's the induced bare metal stent use, times the NHI rate reimbursement for such stent. We can also count in the extra surgery revenue when you say you have more vessel to be treated, and then for the extra vessel, the NHI would have a reimbursement rate for that vessel to be treated by PTCA. Okay, so here's the number. In 2009, here's the actual number of BMS and elute drug stents used. The counterfactual will give us this for BMS. We know the induced use would have almost 3,000 more, okay? The counterfactual will give us the revenue loss to be expected at this number, but because of the induced demand in BMS stent, we're able to recoup this much. There's extra surgery revenue if we count for the higher probability of treating 2 vessels rather than 1 vessel. Putting those numbers together, that would give us about 30 to 47% revenue recouped from the revenue loss. Okay, and we can do the same exercise for 2010. That would give us a similar number, around 30 to 47%, depending on whether we count the surgery, extra surgery revenue or not. So that's for the full sample. We're taking the full sample results. if say we separate the major and minor teaching hospitals separately, and we know the induced demand only happens at the minor teaching hospital, then we can do the similar calculation. And that will make the recoup rate to be about 15 to 20%, depending on whether we count in the surgery revenue. And similar number appear in 2010. So just to conclude, the hospitals do respond to reimbursement rate change under the top-up design. However, they do not convert more PTCA patients to stent patients. Instead, they raise the BMS use per stent patient, especially in minor teaching hospitals, and they don't raise the price in the drug-eluting stents. The top-up design is aimed to reduce patient moral hazard for more expensive treatment. However, it generates another type of moral hazard from the hospital to increase the basic treatment that's fully covered by the top-up design. And we find that hospital is able to recoup about 15 to 47% of the revenue loss due to the rate cut. In other words, NHI is still able to reduce the expenditure to at least half of the extent of what they would have planned without such hospital moral hazard. So in that sense, the rate cut is successful in reducing the absolute expenditure from such claims, despite the hospital moral hazard. So that's all I have. I'm happy to open to more questions.
Okay, folks, we open up for questions. If anybody has a question, please share your thoughts.
So as you explained before regarding the major and minor hospital, the major hospital were using the new stunts which has the economical impact, while the minor one were using the delusion aspect. Why there was a difference between the major and minor?
Yes, and you're right. That's the major hospitals are more likely to use stent. They're more likely to use drug-eluting stent. Their patients tends to be a little sicker than patients in minor teaching hospitals, and they are probably also richer and being willing to pay for the incremental cost of drug-eluting stent. Does that answer your question?
Kunal, is that okay?
Yes, sir. Thank you.
Thank you.
Ginger, I had a question on a placebo group. So is there a group which doesn't do top-up design but is using similar technologically incentive procedures in the context of this NHI scheme where this can be tested, like in terms of a more generalizable welfare finding going back to Finkelstein's paper?
Yeah, that's a very good question. We thought about that a little bit, but we're not successful in finding another condition. Seems like you would need to look into a sort of probably similarly in severity, but somehow not subject to top-up design, right? And that's difficult to find. For example, pacemaker is also under this top-up design. And the reason they use a top-up design was because those conditions are a big driver of the medical expenditure. They want to curb the rise of the expenditure, right? If you look at another condition that would not have such pressure in medical expenditure, then it's probably not comparable to cardiac stent.
Knee replacements, is that also subject to top-ups? Or
That's a good question. Yeah, I can ask my co-author. He may know more about that. I would imagine that, I guess you're talking about the device used in knee replacement, right? Yeah, I would imagine that could be subject to, because I mean, knee replacement is high volume surgery, right? And the device is expensive. Yeah, that's a good possibility if it's not subject to.
And this data ends like a few years after the change of the treatment. So I'm wondering, like, is this a partial equilibrium result? Does it go away over time? Do you worry about it? Uh,
Um, yeah, it's probably, that's a fair question. It's probably very hard to tell that empirically because the NHI is supposed to have the rate change every 3 years. So it will never be possible to see what's the long run impact of the single rate cut.
right. Okay, I'm done. Thank you. Others, any other questions?
I have a question.
Yeah, go ahead.
So you found that minor teaching hospitals increase their BMS per patient. So what could be the possible reasons behind that? Is it because they are more sensitive towards their revenues, or are there any other reasons for this behavior by minor teaching hospitals?
Our empirical results is a relative results, right? We're comparing the hospitals subject to a bigger shock of this rate cut to the hospital subject to a smaller shock. And we find the first group tends to have a bigger increase in the use of bare metal stent. So that being said, I think minor teaching hospitals probably have fewer levers to adjust given this rate cut, right? And they are subject to, they're typically regional, and if the patient is rich enough and be willing to travel, they probably will go to some major teaching hospital. So the minor teaching hospital probably facing relatively local patient population and may not have huge willingness to pay for stent. So I think it's natural for them to sort of push the margin that they can push rather than the price or pushing patients to use more of drug-eluting stent, right? For the bare metal stent, it's relatively easy. The patient just say yes or no. The patient does not pay anything extra, right? And in this world, doctors seems to know much more than the patient. If the doctors say that's now you have so-and-so vessels that need to be treated, and it's good for you to have stent there because it will have fewer side effects or something, I think it's very hard for patients to say no.
Thank you.
But then, of course, there's a question like, if they can induce demand this way, why didn't they do that before the rate cut?
So how substantial is stenting as a part of overall healthcare expenditure in Taiwan? Like it's 15%, 20%?
That's a good
Maybe
question.
maybe you
I don't.
want to mention this in your paper when you submit.
Right. Yeah. That's a good point. I know it's a substantial amount. I don't have the exact percentage, but it's quite a substantial amount. I mean, cardiac condition is one of the leading conditions, right, to
Yeah.
be treated by hospitals, and this is probably the most popular medical procedure for that condition.
Yeah.
And the reimbursement for the PTCA surgery is a little higher than the reimbursement for stent. So the typical reimbursement rate for one vessel is about 25K local currency, while one stent is about 20K. So from NHI's perspective, like they have huge amount in both the surgery and the stent use.
Also, here, would you observe if after stenting, there are like blood thinners being given to the patients? Like there could be some spillovers in demand for pharmaceuticals that are bundled with stents, no? That might be something interesting to study as an unintended consequence of things like
Right.
that. Separate paper, not this paper, but yeah.
Yeah, at some point we thought about that. I couldn't remember why we not focusing on that. You're right. That's for drug eluting, especially for I think for both bare metal stent and drug eluting stent, the patients has to take some drug to avoid the vessel to be contracting again. But this is especially so for the drug-eluting. I think they need to take some blood thinner drugs. Yeah, and in theory, we should have that data.
Okay.
Yeah, that's a good point.
Okay.
But we don't see an increase. We don't see a causal impact of the rate cut on the number of drug-eluting patients, right? So if those extra drug taking was associated with DES, then we may not be able to see a huge effect there.
Right. All right. If there are no other questions, then I guess we can wrap up. Anybody else has a question? I don't miss anything. So I think there is no other question. We can wrap up. Thank you so much, Ginger. Much appreciated. And we will be in touch on the video that we would, with your permission, socialize on our digital handles. And wish you safe health and take good care. Thank you very much.
Thank
again.
you so much. Yeah, thank you so much. Should you have any other comments, feel free to email me. My email address is just ginger@umd.edu.
Thank you. And thanks everyone for staying up for this seminar. Much appreciated.
Thank you, Ginger. Thank you, sir.
Bye-bye.
Thank you. Thank you. Yep.
Bye-bye.
Have a good day.
You too. Bye-bye.
Bye-bye.